right, everyone, we're going to get started. We might have some stragglers, but so this is Dr. Dia. Dr. Dia is a cardiologist in Oak Lawn, Illinois, and is affiliated with multiple hospitals in the area, including Advocate Christ Medical Center. He received his medical degree from Damascus University and has been in practice for more than 20 years. He specializes in heart failure, transplantation, and pulmonary hypertension, just to name a few things. So please welcome Dr. Dia.
Thank you very much. Good morning.
Good morning.
And thank you for coming, and thank you for inviting me to talk to you. I think what we are going to do today to talk about the connection between the kidney and the heart. And usually we say that there is what we call it cardio-renal syndrome. That means actually the kidney can affect the heart and the heart can affect the kidney. And there is no doubt about it. And there are like 5 types of cardio-renal syndrome when we talk about that. But I'm going to go through some of the slides. Please, this is informal kind of presentation. If you have any question, interrupt me, and we'll try to go with that. As you know, chronic kidney disease is a major public health, and 26 million American affected with that, and the prevalence has been between 11 to 13% of the adult population in the United States, as a matter of fact. And it's very costly. It's almost $42 billion in 2013, and whenever you have heart disease or kidney disease, the mortality, that means the death because of the disease, goes up, you know. And you can see that chronic kidney disease increase all-cause mortality from any cause that can increase it. And also, when we reach the end-stage kidney disease, can actually really affect multiple organs, especially the heart. And we'll talk about that in a minute. Now, when you have chronic kidney disease and diabetes, there is 6-fold increase in mortality as well. Unfortunately, chronic kidney disease can affect minorities, especially African American, more than other population. We'll talk about that also in a minute. It's a worldwide problem. Actually, chronic kidney disease in developing country is a huge problem. And you can see all over the world, we are having a problem with chronic kidney disease. And as a matter of fact, you see that from 1990 to 2010, the amount of people just on end-stage kidney disease, not only chronic kidney disease, end-stage kidney disease, that means they require dialysis or require transplantation or peritoneal dialysis or end-stage kidney disease, it's over 2.5 million. This is in 2010. I cannot tell you how many now in almost 2020. So this is all over the world kind of a major problem. Now, the problem is most of the people affected with the chronic kidney disease are not aware of that. And you can see from this slide, even in the United States, actually almost 25% patients are not aware of their kidney problem. Why? It's like hypertension. You know, sometimes you start to have high blood pressure but no symptoms. Chronic kidney disease, no symptoms until late in the game. And that's the problem. That's why we need to be very vigilant about this issue and try to screen those patients who are at risk as early as possible in order to diagnose chronic kidney disease. Even in China, yes, sir.
Excuse me, sir, regarding this early notice, given that patients don't usually find out that they have CKD until they're at least stage 3, can we not have GFRs imposed earlier by mandate?
Very good question. I'm coming to that
Okay.
in a minute, actually. Yes. So that's the awareness, even lower in developing country in the problem with the kidney disease. Now, this is your answer. Detecting of chronic kidney disease is very cheap. and very easy. So to check GFR, I think you are familiar with GFR. It's a kind of calculated formula to see how the kidney is doing. Actually, it's very, very cheap. As a matter of fact, if we check serum creatinine, it's less than $1, okay? If you have a stick to check the urine for the protein, because protein in the urine is a marker of kidney disease, is really very cheap. If we do albumin to creatinine ratio, and this is telling us how much we are secreting protein in the kidney, and this is a sign of, I think you are aware of it, called nephrotic syndrome, okay? Especially people who have diabetes or some other diseases can have nephrotic syndrome. And it's very easy and very cheap to check that. And if we have someone with lower GFR, we need to make sure this is a consistent issue in order to diagnose them with chronic kidney disease. So really, a screening, when you go to your primary care physician, and they do the blood test, and very easy to screen for the chronic kidney disease. Now, who are those people who are at risk? Diabetes is very important because diabetes can affect multiple organs, including the heart and the kidney. High blood pressure, really it's very important. And high blood pressure is tricky. In a way, chronic kidney disease can cause high blood pressure, and high blood pressure can cause chronic kidney disease. And high blood pressure can affect the heart as well. Not only that, can actually cause a stroke. So high blood pressure is very important, and this is they call it the silent killer. Why people are not aware unless you check your blood pressure, you know? And you need to be treated. Some people said, why I should take medication? I don't feel anything. But this is why we should take medication for high blood pressure, because it's a silent killer. Now, cardiovascular disease, if you have coronary artery disease, if you have heart failure, okay? Those are going to affect kidney as well and can cause a problem. Now, as you know, there are some diseases can affect the family. So if you have a family history of chronic kidney disease, you need to be checked for kidney disease. And we'll talk about some of the diseases like polycystic kidney disease. It does run in the family. And polycystic kidney disease, as a matter of fact, can affect also the heart in a way that it can cause high blood pressure and can affect the heart as well. Renal dysplasia or hypoplasia, that means the kidney is smaller. Hypoplasia, that the kidney is small. Some people are born with that when the kidney is small, and this can cause problems. You know, in elderly people, they have a prostate problem and can cause obstruction, and this obstruction causes flow back to the kidney, and it can cause a problem. And if we don't treat this, for example, prostate problem or stones actually are blocking the ureter, then we are going to have more kidney a problem. So some of those risk factors we can change, and some of those risk factors we cannot change. For example, diabetes, hypertension, we can intervene and we can change and we can reduce the risk. For example, the history of acute kidney injury. Sometimes people, they go to the hospital for other illness, for pneumonia, for example, or septic shock, or sepsis, infection anywhere. They can have acute kidney failure, but they can recover. We can treat that. The frequent use of pain medication. A lot of us, we have back pain, knee pains, and we use those non-steroidal anti-inflammatory. That mean over the counter. We have this ibuprofen, all this Celebrex, Aleve, aspirin. If you use it a lot, it can affect the kidney. Yes, sir.
Routinely in the past, baby aspirin has been prescribed to protect against stroke, among other things. Lately, the associations are reversing that recommendation. The question is baby aspirin 81 milligrams harmful also to the kidneys, or only the more high doses?
Any aspirin can be harmful to the kidney, you know, and I agree with you now. The new recommendation for aspirin, they used to say that aspirin can protect for heart disease, stroke. Now, if you don't have risk factors or you don't have coronary artery disease, we should not give aspirin to everyone. And the reason for that is not only the affecting the kidney, but the bleeding from the aspirin. The bleeding from the aspirin, actually, it's the benefit is less than what we see from the bleeding. Yes, ma'am.
Is Tylenol different?
Tylenol is different.
Okay.
Yes. Paracetamol or Tylenol is different. But I want to caution you also that paracetamol, Tylenol can affect the liver. Yeah, so you have to be careful. So anything, we cannot take it in excess unless we need it, you know, unless it's prescribed. Now, some of the risk factors we cannot change. The fact we are older, or there is a family history, or male versus female, or the race, we cannot change, you know. And unfortunately, those risk factors we cannot change. But we have a lot of risk factors we can change, and we can really prevent the kidney disease. If you take the risk factor for coronary artery disease, they are almost the same like kidney disease. Diabetes, hypertension, smoking, elevated cholesterol. Not only that, chronic kidney disease is a risk factor for coronary artery disease. Again, we cannot change the family history, age, gender, and sometimes if the patient is on end-stage kidney disease on dialysis, we cannot change that unless they are actually transplanted, for example.
I have a question, sir.
Yes.
Is the only reason why CKD is on that list is because it generates hypertension, which in turn produces...
Not only that, actually, it's not only generating hypertension. Chronic kidney disease can actually increase the phosphorus, calcium, as you know, and cause hardening of the arteries. Also, chronic kidney disease and coronary artery disease or heart failure is an inflammatory process, which actually can cause the problem again. That's why they actually interact together. Now, if we have patients with chronic kidney disease, they are at high risk of coronary artery disease. That means the blockages in the coronary artery. Okay. Not only that, heart attack, 33% of them. If the GFR is less than 60 ml per minute, then it's like 33%. Heart failure, congestive heart failure, 45%. If the GFR is less than 60, you know. So really we have to be aware. So people who have heart disease, we need to check their kidney and make sure the kidney is okay. People with kidney disease, we have to really check always on their heart and make sure the heart is okay. Not only that, if you go to the end-stage kidney disease, okay, look what happened if the GFR goes down. Look at what happened to the increase of coronary vascular disease. The hazard ratio, that means if the GFR below 15, it's almost fourfold more heart disease in those patients who have very low GFR. Just telling you that this really connection is very important. And don't forget that when we have coronary artery disease and what we call it atherosclerosis, it's a generalized process. It can affect all the arteries in the system. It can affect the arteries in the neck. It can cause a stroke. It can cause heart attack. It can cause kidney problem. It can cause peripheral vascular disease. People, they cannot walk and they stop because of the pain in the legs. This is what we call peripheral vascular disease. So really all this together, and if we can prevent that or treat the risk factors, probably we can slow the progression of that disease. Now, if you take even, that's what I'm saying, if we take even coronary artery disease, or myocardial infarction, or heart failure, or valvular heart disease, those people who have leaky valve, or the valve is really stenosed, narrow, they are more with chronic kidney disease. Even, I talked about the peripheral arterial disease, more with the kidney disease. We did not talk about atrial fibrillation. Atrial fibrillation, the irregular heart rhythm, can happen more with patients with a chronic kidney disease. Not only that, and you see here, the sudden cardiac death, that people, suddenly they die. It's more with chronic kidney disease than without chronic kidney disease.
Regarding this AFib, is the kidney degradation spewing toxins, which in turn cause the heart to have an abnormal rhythm, or some other reason?
Mainly hypertension and coronary artery disease and heart failure, all of them kind of predispose to the atrial fibrillation. And this can happen more with kidney disease.
So it's not necessarily toxemia.
No, not necessarily toxemia, yeah. Now, heart failure, if we concentrate on heart failure a little bit, which is a big issue, you can see that those patients who have actually a chronic kidney disease, stage 1 to 2 or 3 or 4 to 5, they have more heart failure, all kinds of heart failure. Sometimes, I think if you are aware of that, they call it diastolic heart failure, or heart failure with preserved ejection fraction versus heart failure with reduced ejection fraction. All of them can increase with chronic kidney disease, and especially in the late stages of the disease. And this is very important because sometimes patients with heart failure, the ultimate treatment for them is to do cardiac transplantation, okay? And if you have chronic kidney disease, it's actually delaying the process of cardiac transplantation, or sometimes you have to have heart and kidney transplantation in order to really cure those patients. This is very important. Look at the survival of the patient without chronic kidney disease and no heart failure. This is the top line. Now, if you have a chronic kidney disease but no heart failure, the survival is less. If your heart failure without kidney disease is less than before. But if you have a chronic kidney disease and congestive heart failure, actually the survival much less than before. So the combination of chronic kidney disease and heart failure is not very good. And this is only in 1 year, 24 months, actually 2 years.
Would you say then that the solution, other than medical intervention, is aerobics to increase kidney perfusion and strengthen the heart at the same time?
We are going to talk about that, how we are going to treat about that in a minute. Again, coronary artery disease with a kidney disease, or myocardial infarction, the heart attack with the chronic kidney disease, the survival is less when you have the chronic kidney disease with that. How does chronic kidney disease lead to congestive heart failure? And that's what we said, the high blood pressure and volume overload. That means because the kidney cannot get rid of the extra fluid sometimes, and the high blood pressure, all this can affect the heart and cause the heart to be under stress. And when the heart is under stress, really we have heart failure. Not only that, we have something called endothelial dysfunction and inflammation. What that means, endothelial dysfunction, that the lining of the arteries from inside get diseased, you know? So the artery is hard now, does not work as it should. Dyslipidemia, high cholesterol, you know, especially the bad cholesterol, and low of the good cholesterol with kidney disease and heart failure. Elevated phosphate, we talked about that. Low vitamin D levels, all of them can cause the hardening of the arteries and make the heart work harder and then fails at the end.
Sir,
Yeah.
do you agree that vitamin C helps repair endothelial lining so that it's a recommendation?
There is no recommendation on that, and there is no study showed that vitamin C can help. But if you have low vitamin C, it's okay to take vitamin C. Yeah, but there was no nice trial showed that vitamin C can help in this situation. Now, what can we do to prevent chronic kidney disease and heart disease? And you know this ounce of prevention is worth a pound or maybe 10 pounds of cure. Diet and exercise, what you said, it's very important, you know. I think what we need to do, we have to be careful with our diet now. Probably don't eat a lot of eggs per week. The red meat, maybe we should cut down on that. If we are overweight, maybe we should have our dinner around 6 o'clock and don't eat anything till breakfast, okay? No snacks in between. So exercise is very important. How much, yes sir?
When you say cut down on red meat, like what would be an appropriate portion per week?
Twice, maybe. Twice. Maybe eat fish more. Remember this, anything swim or fly is good for you. Anything looking at you is not good for you. So yeah. So chicken, fish, good. Turkey, good. Someone looking at you like meat of cow or, you know, it's not very good.
Do you acknowledge? Do you acknowledge that many articles abound that vegetarians fare better with kidney disease than non-vegetarians?
Actually, vegetarian diet, and I will say mainly Mediterranean diet, is much better than other diets, okay? Because you have more vegetables, olive oil, all this, you know. But I cannot tell, I mean, some people, they need to eat meat. It's okay to eat meat, but I mean, you have to cut back on the red meat, maybe eat more fish, you know. That will be a good idea. But I agree with you, vegetarians are doing better from the diabetes point of view, from the hypertension point of view, which can lead to heart disease and kidney disease.
Is the issue there that animal protein and the fats that often accompany the animal block the kidney capillaries, interfering with kidney function?
Yes, it can actually enhance the atherosclerosis. And remember, atherosclerosis, which means the hardening of the artery, is a very long process. It's taking over time for a long period of time. As a matter of fact, in the Korean War, when the soldiers, young soldiers, died at that time in the range of 20 to 30 age, they did autopsy on them, and they found the presence of atherosclerosis still in young people like 20 and 30 years old. So the atherosclerosis process can start very early and goes over time, okay? This is why we need to be careful with our diet, our exercise. Now, let me go back to the exercise. Exercise, what we need to do, 30 minutes every day. 30 minutes every day, okay? That's what we need to do, at least. All right? Then, if you are sitting, every 1 hour you have to stand up and walk. Every 1 hour. You cannot sit 1 hour more than you have to stand and walk. I don't care. You walk to the bathroom, go to the kitchen, whatever. You have to stand up and walk, unless you are sleeping. Okay? That's what you need to do. Okay? So that's the exercise. Now, smoking cessation is very important. It's the most important thing you do ever. It decreases your risk by 50%. No medication, no intervention, nothing can do what you do when you stop smoking. Okay? 50% of your risk will go down by stopping smoking. So this is really important. Of course, controlling diabetes, and we'll talk about that in a minute. Controlling blood pressure is very important. We'll talk about it in a minute. Avoiding over-the-counter non-steroidal anti-inflammatory medication, like ibuprofen, Motrin, Aleve, something like that, unless you need it and prescribed by physician because of severe joint pain, back pain, or you need it for something. Patients who have chronic kidney disease, they have decreased vitamin D, and you need to make sure that you are supplementing yourself with vitamin D. And regular checkup with the primary care physician is very important, especially early on to catch the disease in the early stages.
Is the significance of the vitamin D that it boosts the immune system or that it increases calcium absorption?
Both, and also it helps with the, as we said, the hardening of the arteries. Yeah, so both actually.
If we take a lot of vitamin D, does it increase our risk for kidney
Yes,
stones?
yes.
What about our bone health and all of this too?
It's very important, especially the patient with chronic kidney disease. They can have actually an early osteoporosis, okay? And this is why replacement of vitamin D, calcium, in a way, it's very important. But you need not to take a lot of vitamin D or a lot of calcium, then actually you are going to have what we call it hypercalcemia, which actually can really make the calcium deposit in the arteries and the kidneys and everywhere and cause a lot of problems. So we have to have a nice balance and check always the blood test to make sure that everything is okay. And as you know, osteoporosis or osteopenia can happen with age also. So not only patients with chronic kidney disease, even aging people, they should look at postmenopausal, at age. We need to look at our bone health also.
Are they still recommending these like Fosamax type drugs?
If you have osteoporosis or osteopenia, yes.
But I thought they were unsure of whether the bone was actually good quality bone that made a difference. You know, it could be.
They showed decrease a little bit of fractures on this.
Okay.
That's why, yeah, fractures. Now, this is what I said about the exercise. I said that it's 30 minutes of moderate intensity. I would say every day. Don't listen to 5 days a week. Every day, we should do it. And maybe if you can, 25 minutes of vigorous exercise will be good also every day. And moderate to high intensity muscle strengthening. That means probably if you have 5 pounds or 8 pounds, you do that, and while you are exercising, you don't have to go to gym. You can do it in at home. Just go back and forth. Do it all the time.
Go
Every day.
upstairs.
Upstairs, downstairs, do this. If you have some, yeah, please do this. And this is really very important. And exercise is important, not only for the health of the muscle or conditioning, but it can lower your blood pressure, can lower your cholesterol. And if you lose weight, especially some people who are overweight, they can have something called sleep apnea, okay? And sleep apnea, as a matter of fact, can increase the blood pressure. So you need to be actually aware of all this. Now, a treatment for kidney disease and heart is almost the same. As you know, controlling the blood pressure is very important. And I think the people who have kidney disease or early kidney disease, and they have some proteinuria, ACE inhibitor or ARB use is very important. ACE inhibitor, that means it's like lisinopril. ARB like losartan, valsartan, something like that. Statin use, that means like Lipitor or simvastatin or something like that. It's very important to control your blood cholesterol, especially the bad cholesterol, need to go down below 100, okay? And the good cholesterol, HDL, should go above 40. Sometimes it's difficult to get it above 40, but if you exercise, it helps to increase your good cholesterol and decrease your bad cholesterol. Now, controlling blood sugar is very important. I'll talk in a minute about that. We talked about smoking cessation, and prevention of obesity is very important. Diabetes control, it's very important. And you know, we have 29 million people with diabetes and 89 million with the pre-diabetes nowadays in the United States. And that means they are at risk of developing diabetes if they don't control their weight and their diet. And pre-diabetes can predispose to kidney disease also. So if you have diabetes, you need to have really a medication or insulin, whatever. And now we have a lot of new medication, actually, to help with the kidney disease in order to control the diabetes. The target hemoglobin A1C should be below 7. Excuse me. Any question about this?
Yes.
Yeah.
Do you see sugar as being equal to salt in damaging kidneys?
I would say more than salt in damaging kidney.
Really?
Yeah. Yes.
Why does post-transplant sugars go higher? Is that because of the medicine?
Exactly. Because post-transplant, what will happen, we give you steroids to suppress prednisone, to suppress and this can increase the blood sugar. Yes. So if you think about the link between the three major problems we have, the chronic kidney disease, diabetes, and cardiovascular disease, it's very linked together. And you can see in the middle, if we have the three of them, it's not good situation. Now, what's the recommended treatment for hypertension? I think this is an old slide, and the recommendation is to get the blood pressure below 140/90. I will tell you what. I would like your blood pressure below 130/80. That's the new recommendation. I don't care. You have diabetes, you don't. You have kidney, you don't. Above 60, below 60. Actually, below 130/80. As a matter of fact, there is a new study. It's called the SPRINT trial in patients who are above age of 65. They brought the blood pressure below 120/80, and they did better. Okay? So we have to be aggressive in the treatment of the blood pressure in patients who have heart disease or kidney disease.
At what number is it so low that there's insufficient kidney perfusion?
Usually we go with what we call it mean arterial pressure, which is a calculation between the systolic and diastolic pressure. And if the mean arterial pressure below 65, it can affect the kidney perfusion and the brain perfusion.
So you don't automatically say a systolic below 100, it's got to be this mean calculation.
Yeah, but I will try to avoid to go below 100 in systolic pressure because people, they get dizzy and they can pass out. It's not good to go below 100. But there are patients who have heart failure, chronic heart failure. And as a matter of fact, they have blood pressure 80 to 90 and they are doing well, which is okay. Okay? If they are not symptomatic, which is okay. Yeah. We can have an impact on the progression of kidney disease. Glycemic control, that means controlling the diabetes to bring the hemoglobin A1C below 7 or around 7, it's very important. Blood pressure is very important. And see what I said, that's what I would like your blood pressure to be, 130 below 80. And then you actually, if you are above 130/80, you have hypertension. And so many times you go to the physician office and your blood pressure is 135/85. Say, oh yeah, they have good blood pressure. No, you are hypertensive. You know? You are hypertensive. And especially if it's consistent like this. You know, blood pressure can go up and down, you know? But if it's consistent like this, you are hypertensive. Cholesterol control is really important medication. Now we have a lot of medication to control blood sugar, cholesterol, and we need to bring the LDL, as I said, the bad cholesterol, below 100, and we should really treat those patients aggressively, especially if they have coronary artery disease, diabetes, and prior stroke, or they have family history, or actually they have chronic kidney disease as well. And remember, those medications, actually, they don't only work on cholesterol, they do work also in inflammation. So they have multifactorial, actually, benefit in patients with coronary artery disease and kidney disease. Complication of chronic kidney disease, which can affect the heart, anemia. As you know, anemia is very prevalent in patients who have chronic kidney disease, and can actually increase heart failure and can increase angina or coronary artery disease. So that high blood pressure, we talked about that, high calcium and phosphorus, we talked about that, which can cause the hardening of the arteries. Now, look at this. This is very, very interesting. If you take the whole population in the United States, third of them, like 31%, they die from heart disease. If you take chronic kidney disease population in the United States, 42% they die from heart disease. Okay? So that means if we really treat the cardiovascular issues in those patients with chronic kidney disease, we can decrease the mortality of patients with chronic kidney disease and heart disease. Make sense? Yeah. And remember, infection is higher also in patients who have chronic kidney disease. So the key message here, chronic kidney disease, cardiovascular disease, diabetes, hypertension are very common and related. And as I told you, we have what we call it cardiorenal syndromes, and there are 5 types of cardiorenal syndromes. Acute heart problem can cause acute kidney problem. Chronic heart problem can cause chronic kidney problem. Acute kidney problem can cause acute heart problem. Chronic kidney problem can cause chronic heart problem. Or a disease outside the kidney and the heart can affect both, like diabetes, lupus, something like that can affect both. And so there are 5 types of cardiorenal. So lifestyle is very important. Diet, exercise, smoking cessation is the biggest risk factor, and the main treatment is prevention to those patients. Regular visit to your primary care physician is important to screen and manage these diseases. I think this is the last slide. Thank you very much. If you have any question, I will be more than happy to answer. Yes.
Is coronary artery disease reversible?
Maybe not. So, as I said, coronary artery disease is a long process. It starts at young age. But what we can do, actually, we can slow the progression of the coronary artery disease when we actually treat those patients with controlling diabetes, hypertension, the exercise. We can slow the progression of the disease. And if they have significant blockages, now we can treat with stents, or if they have heart attacks, we can do stents or bypass surgery, and we can actually prolonging the survival of those patients. Yeah. So we have good treatment for that. Yes, ma'am.
I wanted to ask you if, like I'm a transplanted person, do I still consider myself as somebody with chronic kidney disease?
Yes.
Okay.
Because you need to continue to manage the risk factors, because I would like you to prevent, excuse me, having any problem with your new kidney, especially high blood pressure. Some of the medication you are taking can cause high blood pressure. Yeah.
Okay.
To control your immunosuppression,
Right.
can cause high blood sugar, can cause high cholesterol.
Okay.
So you need to really control those very, very, very aggressively.
Okay.
Yes, sir.
To this lady's question about reversal potential for cardiovascular disease, do you agree with Dr. Michael Clapper that if you stop shoveling the cholesterol into your mouth, that the liver can have an opportunity to go and clean the existing deposition of cholesterol from the arterial walls?
I don't agree totally with that, because what happened, cholesterol is two problems. One of them, what we are eating, but also, it seems with age, the liver is now providing more cholesterol. Actually, the liver does not clean any cholesterol, actually provide cholesterol, okay? And so what you are doing now, you are trying with exercise and dose medication to try to prevent the liver from producing more bad cholesterol, in addition to the diet to reduce. So liver does not clean cholesterol. Liver actually produce cholesterol.
So there is no organ responsible for removal of cholesterol from the bloodstream?
The medication, and decreasing the amount of cholesterol you are taking by diet. Yes, ma'am.
Doing a stress test, to do the chemical stress test, is that harmful to the kidneys?
No. Absolutely
Because
not.
I had two different opinions, one says,
Oh,
oh,
no,
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 don't
no,
do
no.
that,
Oh, no. Actually, the chemical stress test, we do it on all patients pre-transplant to make sure that
Because I just had a stress test and I'm almost falling down with the other one, so they said, well, we'll have to do the chemical one next time.
No, the chemical is okay. The chemical is okay.
What is the advantage of always going for a test, and how often should you do it? A stress test on a...
No, there is no routine stress test. The stress test usually is done if you have any symptoms of chest pain or shortness of breath or something, or if you have bypass surgery before, or if you have stent before, then they can do stress test after 5 years or 3 years after the procedure. But there is no routine stress test to be done. I'm choking, it seems.
Yes.
Thank you. Yes. So there is no routine stress test unless the physician finds something and they need to check on that, like chest pain, shortness of breath, or abnormal EKG, abnormal echo, something like that.
If they just want to find out if you're short of breath, they'll do that.
If you are short of breath,
If you're not, but they just don't
if
know.
you are asymptomatic, there is no reason to do screening stress test. Unless you are going to rehab, sometimes they do screening stress test before rehab.
You might be referring to.
Any questions?
Is there any significance to blood pressure tending to be high every morning, and by afternoon or evening, no problem?
This is a very good question, because our blood pressure tend to go up and down, and there is something called circadian rhythm. And in the circadian rhythm, the blood pressure tend to be higher in the morning, because when we try to wake up, what happened, there is a hormonal surge secreting like steroid, epinephrine, and can cause the blood pressure to be higher. So don't check your blood pressure when you wake up immediately from sleep. Maybe the best thing is to do, when you check your blood pressure, I ask my patient to have a journal for their blood pressure, and what I ask them, one day to check it probably 10 a.m., one day in the afternoon, and one day in the evening, and write them down, okay? And when you need to check your blood pressure, you need to sit down, calm, for 10-15 minutes, and put the cuff at the level of the heart, okay? You cannot do this or do this and check your blood pressure. So you have to be at the level of the heart and check your blood pressure and write it down. Also, you cannot smoke and check your blood pressure. It will be high. Yeah, it will be high. So don't do that. Your blood pressure will be higher. And then you write them down, and you can see the fluctuation of the blood pressure in that manner.
As a part of that hormonal surge you speak of, pursuant to the circadian rhythm, Are stress hormones also included in that surge?
Sure.
I see.
Yeah, yeah.
For those who are not morning people.
Yeah, but also people who are actually have sleep apnea, can cause surge of high blood pressure if they are not treated. So sleep apnea is actually very prevalent, believe it or not. 40 to 50% of population, they have sleep apnea. And not only people who are obese, actually thin people can have sleep apnea. Yeah, and if you are actually snoring or tired, fatigued during the day, or your partner in the bed notice that you stop breathing during the night, and they kick you and say, oh, breathe. You know, this is high blood pressure also is a part of it. So really, we are underdiagnosing also sleep apnea on our patient. Yes, sir.
Another thing that often happens after transplant is, I think they call it POTS, where your blood pressure
Yes,
drops
yes,
when you stand.
yeah, yeah.
How do you deal with that?
That's very difficult to deal. POTS, it's postural orthostatic sinus tachycardia syndrome or hypotension syndrome. And this is related to the actually autonomic dysfunction. What that means, there is autonomic neural, to the heart, to the vascular, to the kidney, everything. And most of the time, people who have diabetes or those kind of diseases, sometimes people who have Parkinson's disease or something like that, they can have what we call it orthostatic hypotension. And this is difficult to treat. Usually what we do, I ask them to have thigh-high TED hoses, to wear it, They need to do exercise. They go to the do exercise with the wall like this, okay? When you wake up from sleep, don't get up immediately. Sit at the edge of the bed for like 20, 30 seconds, And all of this fails, there are some medication we can use for that, yeah. But this is a difficult problem to treat, yeah. Yes, sir.
If somebody is taking blood pressure medication and they wish to monitor their blood pressure at home, should they take their blood pressure before they take the medication, after they take the medication, or 12 hours after they take the medication? Or doesn't that matter?
Does not need to be related to the medication. Because when you are getting the medication should be long acting to check, to help the blood pressure all day long, okay? So it does not matter, yeah. But as I told him, what I'd like you when you check your blood pressure, check your blood pressure one time in the morning, like around 10 o'clock or something like that, one time in the afternoon, one time in the evening, and write them down, yeah. And now I think there are some blood pressure machines you can buy, and they have app on your phone, and actually it can track your blood pressure. Yeah, so that can help a lot. Yes, ma'am.
What medical tests should we be aware of, for when they want to use contrast medium? Like the lady was talking about the stress test, and also.
But stress test does not have contrast. Okay. Contrast is only when we do CAT scan or coronary angiogram.
Or the MRI.
MRI is different kind of contrast. So the test will be creatinine or GFR
Okay.
to check on the kidney.
Do they still use gadolinium?
Yes, for MRI.
If without a kidney transplant, would we be well advised to refuse that?
As a matter of fact, any person who has GFR below 35 or on dialysis, we should not use gadolinium on them. The people who are transplanted, I will avoid to use gadolinium also. Yeah.
If we did not know we had kidney disease and we had an MRI with gadolinium, could it have damaged our kidneys further?
No, actually, the gadolinium is not only to damage the kidney, it has side effect on the skin and some other problems with that. But the iodine contrast, it's for the CAT scan or the coronary angiogram, can actually damage the kidney. Yeah.
Are you familiar with any studies indicating that kidney patients can have reversal of damage by the oral use of the industrial solvent DMSO?
I'm not aware of any study like this, no. Last question, because I think we are going to be out of time.
If you have a kidney failure, I mean, you're at 15%, but you do not have a kidney disease.
It is kidney disease. When there is kidney failure, that means it's kidney disease.
But if all of, like the phosphate, the calcium, and the sodium, and all of those things, if they are
Could be
normal,
yeah, could be in a stage 2 or stage 3 kidney disease, and you are still, but there is disease. When there is, when the GFR is low, that means there is kidney disease.
so that
But what's the
means-
cause of that kidney disease? It could be because of the heart, it could be because of the high blood pressure, it could be because of diabetes. So yeah,
Dialysis or anything.
that means there is kidney disease,
But I do.
and we have to watch for that.
My PCP says she has a GFR of 85, and she's not concerned. Isn't that the beginning of kidney disease?
Yes, normal GFR above 90, 95, yeah, I agree, and should be very careful with when it's 85. Yeah. Thank you very much, and I appreciate it.